All right, I think we'll go ahead and get started at 10 after. I have the pleasure of introducing Dr. Richard Schaefer today. Dr. Schaefer received his medical education at Rush University and completed an internship at the University of Louisville Hospital and a residency at the Medical College of Wisconsin. Dr. Schaefer is board certified in plastic surgery by the American Board of Plastic Surgery, and he's been with us since 2015.
2005.
Oh, sorry, 2005. Oh, no.
I'll take the extra 10 years ago. Well, thank you, Russ. All right, well, thank you all for having me, and Happy New Year to everyone. Pretty informal lecture, so if anybody has questions at any time, please just ask. So, conflicts of interest. I have no financial interest to disclose. I've made every effort to make this presentation free of commercial bias, and none of these pictures are mine, and precise references are available to anybody who wants them. So our objectives today, I'm going to go out of order from what was on the sheet. So I'm going to go over just some commonly performed procedures that I do locally. I'm going to touch on how NCCN guidelines are changing and recently changed regarding the surgical management of melanoma. And then I'm going to talk a little bit about breast surgery. So what plastic surgery procedures are done locally? So as I think most people automatically assume that I spend all day doing this and that I don't see any patients with insurance. But I mean, I do these things, but this is not the bulk of my practice. So whether it's breast augmentation or a breast lift and a tummy tuck, sometimes known as a mommy makeover, or other contouring procedures, okay, yes, I do them and I enjoy doing them and they're fun and they're great, and doing office procedures like botulinum toxin to be not commercially biased, and other lip and facial fillers. We do these things all the time in the office, and patients love it, and we enjoy doing them. But this is how I spend about 20% of my time. How do I spend the other 80% of my time? Well, dealing with insurance companies like all of you, which is really great fun, and my nurse loves the insurance headaches. Isn't that great? Hey. So, what do I do that's covered by insurance? Well, breast reduction is one thing, and breast reduction over the years has just gotten more and more difficult to get approved. The insurance companies seem to put up more hurdles to get these things approved, but we still get the bulk of people approved. So it can be done. It just takes a little bit more work on our part, sometimes a little bit more work on the patient's part, but we still can get it done. Breast reconstruction, another commonly performed thing that we do. And then a lot of times when people have breast reconstruction or even breast cancer treated with lumpectomy and radiation, they may end up with asymmetry, and asymmetry procedure is a covered benefit. So if you have patients that are even 20 years out and they have some asymmetry that they don't like, or you notice that it seems like it would be burdensome to them, we can easily take care of that. That's covered by insurance. Oddly enough, eyelid surgery is often covered by insurance as well, and especially in the older age set. We treat a fair number of Medicare patients who have upper lid aging. It starts to create almost like a blinder effect for them, and we'll take care of their upper lids and their brows if necessary. And then certainly skin cancer, and our dermatology department is down by one, and so that makes me almost a secondary dermatologist sometimes, and we do a lot of skin cancer excision in the office and sometimes in the operating room, and I'll touch on that in a little bit. Of course, other skin and soft tissue reconstruction, and quite a bit of hand surgery, and even more. So what are some of those more things that we do? Treating varicose veins in the office is actually, I really enjoy doing it. We insert a catheter into the varicose vein and are able to seal it shut. Patients walk in, have the procedure, walk out. Very effective and very satisfying to do. Dupuytren's contracture and the treatment of it has come a long way over the past decade. And I'm sure you see this in some of your primary care patients, just when you're shaking hands with people. Often starts out as a nodule in the palm of the hand, but can certainly create cords and rope-like scars in the hand. And over time, it will start to curl the MP joints and the PIP joints and down towards the palm of the hand, resulting in loss of extension capacity. But their tendinous structures are still completely normal underneath that, but they just cannot get normal range of motion either actively or passively. So the classic treatment for this was surgery, and you usually make what we refer to as a Brunner incision, go in and completely clear out all of that diseased fascia and allow that finger to straighten back out. Nowadays, I do about one of these for every 25 of these I do. And so this is collagenase. When the patient shows up at the office, you mix up the powder and the diluent, let it reconstitute, and then very carefully inject that into the cords and let that collagenase enzyme work on the cord for 24 hours. And then you bring them back to the office and you're able to manipulate their hand back into a straightened position. No incision. Certainly you still get some discomfort with it, most commonly referred to as pain, but certainly just called discomfort after the procedure. And then a little bit of hand therapy, some night splints, and you can have a very nice result without a trip to the operating room. Endoscopic carpal tunnel release is a procedure near and dear to me. I've been doing it here for over a decade. Do several hundred a year. I really love this procedure. It allows me to do the entire release through a tiny incision in the wrist. We're able to insert the scope with the triggering mechanism blade that allows us to release the entire transverse carpal ligament through its entire length. When we're done with the release, we reinsert the scope showing full separation of the leaves of the released ligament, and very satisfying to do. Basilar thumb arthritis, so the trapezium and the thumb metacarpal break down and get arthritic changes because this is one of the few saddle joints on the body, leading to pain. You see this a lot in ladies, certainly after 50 years old or so, often treated with splinting and steroid injections. But ultimately, this degeneration gets so painful that they lose thumb function because of pain. And the long-term treatment has always been trapeziectomy by and large. Now, once the trapezium is removed, there have been a multitude of surgical interventions that have been described to pad the metacarpal and to prevent it from subluxing further into the wrist. The technique that I've adopted most recently, which I've had very good luck with, is suspending the thumb metacarpal to the second or index metacarpal with a piece of fiber tape, and this allows for very quick motion recovery after surgery, and it prevents, it allows me to avoid harvesting the flexor carpi radialis tendon, which has historically been used, and sometimes people would refer to as an anchovy or a wrap that would go in the space where the trapezium used to be. And then melanoma. Melanoma, obviously a form of skin cancer, and this is sort of my segue into the next objective, which is recognizing how NCCN guidelines have changed regarding the surgical management of melanoma. So I like to use the NCCN guidelines. It's a multidisciplinary expert panel, and it's frequently updated. And unless I have just looked at the NCCN guidelines, when I have a melanoma patient who show up to the office, I almost always just go back and see if they've updated them again, because they update them with great frequency, and you could have looked at it 3 months ago and they'll have a new version out. So this was most recently changed again November 1st, and they're referring to this version as version 1.2019. So surgery of the primary tumor has really remained very much the same over the years, which is excision of the primary tumor using 1 to 2 centimeter margins, and this has always been based on the depth of the primary tumor. However, the threshold for performing sentinel lymph node biopsy has significantly changed over the past 15 years. And the recommendations have always been based on tumor thickness, but when they use tumor thickness, they've changed how thick of a tumor they recommend. And the thinking is that if the risk of the melanoma spreading to a lymph node is less than 5%, then there's no reason to interrogate the lymph nodes with a sentinel lymph node biopsy. If the risk is between 5 and 10%, or the risk is unknown, then you should discuss and consider sentinel lymph node biopsy with the patient. So you might say to yourself, well, why would the risk be unknown? Well, the reason why the risk would be unknown is because during the biopsy of the primary tumor, if the provider didn't recognize it as a melanoma, or even did recognize it as a melanoma when they did the biopsy, if they went through the base of the lesion, you will get an incomplete depth. So pathology will read that as a positive deep margin. And so if we'll just, for example's sake, say you shave a lesion, it comes back as a melanoma, but the depth is 0.5 millimeters. Well, you can reliably say that it's at least a ½ millimeter thick, but you can't then go back and reshave it and start to add up what you took out the first time and what you see left behind to try to get a true depth. And the depth of the tumor is really what's driving your surgical decision-making as to whether or not you're going to be performing a sentinel lymph node biopsy. So that's why sometimes the risk is unknown. And so if the risk is higher than 10%, then we recommend having a sentinel lymph node biopsy. But from time to time, there are other medical comorbidities that patients present with, and we just don't do a sentinel lymph node biopsy on people for certain reasons. So the current recommendations in version 1.2019 is that if you have a melanoma that's thicker than 0.8 millimeters, then you should really consider getting a sentinel lymph node biopsy performed. Okay, and this is really the newer indication that's more atypical. You understand that if it's thinner than 0.8 millimeters, if there's ulceration seen, then that would be a reason to consider sentinel lymph node biopsy. And even if there's no ulceration and it's less than 0.8 millimeters, if there's a high mitotic rate, which would be 2 or more mitotic figures per high power field, or if there's lymphovascular invasion seen, especially when combined with a patient who is young, this would be a reason to consider sentinel lymph node biopsy. So I think the key messages are that the depth of the primary tumor remains the most important feature in guiding surgical decision making. So if you're going to perform a biopsy on a suspicious lesion, you've got to go deep enough. The other thing is that sometimes we'll see in the office is what I would refer to as sampling error. So here's a picture. The guy with the lesion on his lip. If you took a 3 millimeter punch biopsy, I mean, you look at it and you're like, okay, this sort of looks a little worrisome. This is lentigo maligna. Is it an invasive melanoma? I don't want to, in the office, take this whole lip apart. I just want to confirm that this is a melanoma, and I'm going to send it to Schaefer, and he'll take care of it, which is fine. I'm happy to do that. But so let's just say you biopsy the top corner of this thing or somewhere bottom, doesn't matter, but you're going to do a 3-4 millimeter punch. You go plenty deep, that's great. The trouble sometimes becomes is that so if your sample comes back, again, I'll use ½ a millimeter thick, that's fabulous. You've proven it's melanoma. We know it's ½ a millimeter thick. I'm still trying to figure out if I have to do a sentinel lymph node biopsy. Now, you can do sentinel lymph node biopsies after the primary tumor has been excised, but it's not the recommended way to do it. They'd like to ideally have your sentinel lymph node biopsy done at the time the primary tumor is excised so that you're not altering the lymphatic flow of things. So if this portion of the tumor is ½ a millimeter thick, well, now I know it's a melanoma. Now I know I've got to excise it, but I still don't know if I have to do a sentinel lymph node biopsy. So in this situation, were that to occur, I might, in the office, do another biopsy or two to try to prove that it's at least Now, the current indications, either ulcerated, has a high mitotic rate, has lymphovascular invasion, or has a depth of at least 0.8 millimeters thick. Because then I can reliably tell the patient, okay, your risk for metastases to your local lymph node basin is at least 5%, 10%, whatever it is, and therefore we should be performing sentinel lymph node biopsies. So sometimes we do have to still, even though patients sometimes show up at the office with a diagnosis of melanoma, we may take additional biopsies before proceeding to the operating room. All right, so now I'm going to shift gears and talk about the breast. So, the goal for breast reconstruction is to really satisfy the patient's individual's needs. And so we have to talk about size, shape, we're going to do one side or both sides. And ultimately I think most ladies want some amount of symmetry. And this, to get you from a one-sided breast cancer to bilateral symmetry, is rarely perfected in a single operation. Okay? It's generally a process. Oftentimes it's a multi-step process, often requiring multiple trips to the operating room, and that's how it is. Okay, so this is the same way I start out my conversation with patients as I'm telling them about what we're going to do as far as the reconstruction goes. I think it's always good to just start, well, what are you starting with? Well, what is a breast? So a breast is skin, right? And then there's a nipple and an areola, which come in a variety of size, shapes, and locations. And then you have fat and breast parenchyma within the breast. And all of this sort of contributes to the appearance of the breast. And so here's a slide I picked up off the internet, and it was about a company trying to sell bras. And they've got all sorts of bras that they'll sell you based on how your breasts look. I particularly like this one down at the bottom. That's the US type of breast. Look at that, that's great. This is what they think of the US and Europe, okay? Now, mind you, this is all on women that look the exact same. I mean, this is like a normal, healthy BMI lady, and she's got 16 different sizes and shapes of her breast, okay? Now we're gonna add in bigger and bigger and bigger size patients that we see all the time here, right? I mean, you have this patient walk into your office, we're all like, oh, hallelujah, right? So getting, I can give a lady a reconstruction look like this, but if her other breasts look like that, she's not going to be so happy, right? And you can't just go from one to the other. And obviously, this is the U.S. breast, so this is what we're dealing with. So the appearance of the breast also has to do with age and weight, right? Their current weight. What did they weigh before? Maybe they weighed 400 pounds before. The tone and the quality of their skin, their previous cycles of lactation and involution, whether or not they've had surgery to their breast before, whether or not their breast has been radiated before, the location of their inframammary fold, the size of their areola, and the size and shape of their chest and their rib cage, because that really also alters how things look. Now, all of these things have to take into consideration when we're trying to give people, a pretty breast, because I think ultimately everybody, when they're done, wants a pretty breast. And so what is a pretty breast? Well, a pretty breast has a balanced relationship between skin and fill. And it takes on a shape that is rounded without harsh edges, and it's soft and it's full. And the volume of the breast should be proportionate to the patient, not only their chest, but ideally their waist and their hips. The nipples should be at a point of maximal projection on the breast. They shouldn't point up, they shouldn't point down or left to right. And ideally, the areola is also proportionate to the breast. To talk a little bit about the surgical options, basically women choose between lumpectomy and mastectomy. Lumpectomy patients are going to be getting postoperative radiation. And mastectomy patients, really the hope is that they can avoid radiation, but that's not always the case. When you have a mastectomy, it can be done as a skin-sparing mastectomy, and more frequently as a nipple areolar sparing mastectomy. When we're using implants, we have a variety of implant options. We have tissue expanders. So an expander is something that we can change the size of after surgery is done, and we change it in the office. And there's two ways we do this, either with a remote port, so there's just like a chemotherapy port. This is under the skin, You feel it, you access it with the needle, you inject saline into it, and it fills the implant, okay? We also have a classic tissue expander, which is an integrated port. So here you get a magnetic finder so that you know where the magnetic hub is, and you are able to access this without rupturing the integrity of the device and can add saline this way. I used to do 90% of my reconstructions with implants using a remote port implant. The remote port implants, the ones that we're using, have been discontinued. So I'm now doing almost exclusively integrated ports. We can also use, and sometimes do, we'll go direct to implant. We call it a permanent breast implant. They can be filled with saline or silicone. Permanent breast implants is somewhat of a misnomer. It's permanent insofar as that if you put one of these silicone breast implants on a shelf in your bedroom and you left it there, you would die before it does. However, if you put it in a person, it gets wear and tear, and they fail at a rate of about 1% per implant per year. And when an implant fails, then we should replace it. So it's permanent insofar as it's not going anywhere. It's not necessarily the last implant that a patient is going to get, especially depending on their age. So I think this is interesting. So the historical progression of implant reconstruction. So it's gone from a subcutaneous reconstruction to full muscle coverage. Some people toyed with partial muscle coverage, and then went to what we would refer to as a dual plane. And I was doing this dual plane reconstruction pretty much since I got here. And then we have prepectoral, which I'm doing almost exclusively now. So the subcutaneous reconstruction was first described back in 1962, and this was done with a Halsted mastectomy. And for those of you who aren't sure what a Halsted mastectomy is, that would include removal of pectoralis major. So putting it under the muscle wasn't an option. The muscle was taken with the breast. And so, surgeons were basically putting in an implant underneath a fully excavated breast, and they had lots of problems with it. They had exposure and visibility issues and contracture issues, and it was really thought to be not very good. And it wasn't until 1975 that the muscle-sparing mastectomy was considered cosmetically better and safe as long as the posterior margin of the breast could be adequately cleared. Well, once the muscle started being left behind, it opened up a whole new world of reconstruction. And so if you look at what we're talking about the pec major, okay? But this is not a female-looking chest by and large. It's a fairly masculine chest with a fairly large pec muscle. So you look at this drawing and you're like, well, this will be easy. There's plenty of muscle to put an implant under. It'll be okay. But the other thing we have to consider, not only this is a masculine chest and we're going to be doing it on ladies, but the other thing that I think we have to understand is that we've all been to the anatomy lab and we've all seen people come in all sorts of shapes and sizes. Some people are very muscular, some people are not. Some people have what you might refer to as anomalous insertions. Some people have a very wide sternum, some people have a narrow sternum. Sometimes the muscle is much further lateral than this. Sometimes it's very diminutive down in the bottom. And these are all important as it relates to the reconstruction. So a true, in that evolution from going to a Halsted mastectomy with the removal of pec major, basically, when I started residency, we were doing, and when I was in med school, we were doing all submuscular, 100% submuscular reconstruction. So, you'd walk into an operating room, you're looking at this beautiful pec major that's left behind, you do a muscle splitting incision, and you create a pocket under here, and you put an expander in there, and that is how you would initiate the reconstruction. Well, I'll tell you that the pec sits on the chest differently than the breast does. And that's why sometimes you got lucky because the pec sat in a favorable position, and other times the pec sat in an anomalous position or a non-beneficial position. It didn't really look so much like a breast. But of course, when you draw a cartoon of it, look, it's perfect. You've got a beautiful reconstructed breast, and you just put that implant underneath the pack, and it works great every time. The artists always make it look much easier than it really is. Oftentimes, the serratus was being violated and used as well to help gain that full muscle coverage. And when people started to realize that these reconstructions weren't looking very good and were sitting oftentimes too high and too lateral, surgeons started to go from this full muscle coverage to partial muscle coverage. So they would do the same operation, but instead of trying to get this bottom of the implant 100% covered, they would blow through the bottom of the pack, and they wouldn't do extra effort that some surgeons were doing. Were trying to use fascia from the rectus musculature, which is inserting right from underneath it, or using some of the serratus. So they were sort of letting the bottom of the implant just sort of free ride down here. The problem with that is that the pack will continue to contract over time, and that implant will just get displaced further inferiorly and laterally, which is not where you want the breast, and not where you want the implant. You want that more medial and appropriately positioned. And it wasn't until the early 2000s that acellular dermal matrix really came to the reconstructive scene. And so acellular dermal matrix is a human or porcine dermis. It goes through a series of proprietary tissue cleansing and stripping, making the structure devoid of cells and functionally inert. And it essentially resembles a piece of leather that is just a sheet of collagen and other dermal proteins. And when you put it into a person, there's no immunologic response, and the patient will grow a blood supply, and their patient's tissue will ingrow into it, and it will become part of them, and it will incorporate. And so this is often used for soft tissue support, and this revolutionized the appearance of breasts as it relates to the breast reconstruction with implants. And early adopters of this, 2004, 2005, I only saw a couple of these procedures done on my residency, and when I came here, this is what I started to do. So here's a cartoon rendering, pec major. You get the implant closer to where you want it. It's allowed to sit a little lower. The ADM is sewn in along the lower inframammary fold and is sewn up to pec major, and that expander then will sit under this muscle alloderm ADM coverage, giving you this dual plane. Now, the real benefit of this is that it allowed the expansion process to go faster. It was slightly less painful than 100% muscle coverage, but the biggest gain was in the lower pole. Now, it was still limited by the pack, so that if you had a wide sternum, you still couldn't get that implant medial enough as you wanted it sometimes. And so this was the sort of state of reconstruction up until a few years ago, when here's a picture, intra-op, mastectomy skin flaps, ADM sewn in along the inframammary fold, pectoralis major coming down, the expanders in there. The other great advantage of this dual plane method is that you were able to get the implant out to volume much faster. So you were getting a faster expansion. You could take up the slack and the skin and the stretch. You weren't bound by how much you could stretch the pec on table. You could get pretty much as you wanted out of it based on the size of the ADM you were using. But these ADMs do have problems associated with using them, and that is you've got to get them to incorporate, and is the most critical function of the procedure. And I think that was overlooked early on in the evolution of reconstruction, because the muscles always just healed up nicely, but this ADM sometimes healing with it is difficult. So what are we doing now? So pre-pectoral reconstruction is really how the majority of breast cancer reconstructions are being done, not just here, but nationwide now. And what this does, it allows us to completely cover the implant with the ADM. We tack it to the chest wall, creating what we would refer to as a foot plate of where we want that reconstructed breast to be. We can slide it as far lateral, medial, superior, inferior as we want. So the implant position is much improved. Because we're not violating pec major, this operation is much more comfortable for patients. And the operation has actually become much faster because of this. So really the benefits of prepectoral reconstruction is that it's a lot less pain for patients. They have a rapid return to arm function. My portion of the surgery is now much shorter, which just means the patient gets off the table faster. I think most importantly, we can put the implant in a better position, which gives us better cosmesis, because the implant can be lower and more medial. And then this animation deformity idea is that when you're under the pec here, just like you were before when you were full muscle coverage, when you go to move your arms, lift something up, when the patient activates their pec, it's going to move their implant. And so, you know, this true submuscular and even the dual plane, these ladies would occasionally complain, and sometimes bitterly so, about this animation deformity. But when you're going above the muscle, that is completely eliminated. So I think overall it's been a victory on so many levels. However, I think it's also changed our thinking about the alloderm, because now, or the ADM. The ADM is such an enormous component of the reconstruction that our initial focus used to be on getting it to look nice, and now the initial focus is, you know, we want it to look as nice as we can, but we're really just trying to make sure that we do everything we can to get this alloderm incorporated as quickly as possible. And so, you know, before we were saying, like, how big can we make the implant right away on the table? You know, we want to stretch everything out, but then that was also challenging the compromised blood supply to the skin flaps. And so now, you know, like I did a case a few hours ago, I didn't put any saline in the implant, so it only has air in it and it's gently filled. The air has been shown to cause less tension on the wound and be better for flap survival. Almost all my skin flaps now get nitro paste applied to them to just facilitate blood flow to them, and then they all get a vac-style dressing referred to that is a way to help facilitate early wound healing. And then with that vac-style dressing, there's essentially a large tegaderm bra in there, and I think that really reduces shear. And just like when you're trying to get a skin graft to attach to a donor, shear is the enemy of healing. And so if you have shearing going on with the outer layers of the skin, with the under layers of the attached alloderm, you're never going to get incorporation to occur. So keeping that breast as still as we can in the first few weeks after surgery is critical. And I found that this technique has just changed my practice incredibly. So what other options are there for breast reconstruction? You know, women sometimes choose immediate reconstruction, but often delayed reconstruction is also perfectly acceptable. We see a fair number of those. Partial breast reconstruction after lumpectomy and radiation. Sometimes people have, you know, a moderately good cosmetic result and don't, and just want it to be a little better. They have a little divot up at the top or something. We can fix this without an implant, without doing a major autologous shift. We oftentimes will do fat grafting. Fat grafting is basically taking liposuction. And I've yet to have a patient say, "Oh, please don't do liposuction on me that my insurance is going to pay for." You know, so we do liposuction instead of throwing the fat out. We harvest it, we cleanse it, we purify it, and we put it back into these contour changes. And it's been people have been very happy with that. You can do a procedure sometimes referred to as oncoplastic surgery. So that's where the lumpectomy is done. And once you've sort of confirmed that your margins are clear on the table, then you can reshape the breast before the radiation happens. And I think that this is an emerging trend. We're not doing a ton of it here, but I have done a few cases. Direct to implant. For the right candidate, they show up with the right shaped breast ahead of time. We can go direct to implant with the use of ADM. Tissue expander ADM is probably our most common, but we still have autologous options, whether we're using skin and muscle from the back or the belly. This is always good to have in your back pocket. I prefer to use this in a second stage or delayed. When patients have had radiation, I almost always go with an autologous reconstruction. I seldom go with an expander ADM in someone who's had previous radiation. As I said before, getting a pair of breasts to look great with one operation is hard to do. So here's an example of a lady who's had an implant reconstruction, but she has contour deformities in the medial breast and the upper breast. And this is where we see it most often, is that that implant just doesn't sit necessarily all the way this far over, or all the way as tall as the general surgeon goes sometimes when they're taking out the breast. And so if the patient has this sort of step-off deformity between an implant and what we see peripherally, especially medially and superiorly, then we will do fat grafting there to supplement that. If a patient comes in, we may be replacing her expander, putting in a final implant, doing some fat grafting, and then doing breast reshaping to the other side to give them, the best shape, form, and symmetry that we can. After cancer is all over, if patients have asymmetry, even if it's years afterwards, all this is an insurance covered benefit. Questions?